and gentlemen, please join me in welcoming Dr. Fauci to the virtual Fast Track Cities 2020 conference. Dr. Fauci.
Say thank you very much. I really appreciate the opportunity to address you today. Let me see if I can get these slides up first, and we'll get started. Okay. So as shown on this first slide, I'm going to be talking about the public health and scientific challenges of COVID-19. Obviously, I don't need to emphasize to this audience the importance of this topic right now, which has really essentially occupied the attention of the entire world over the last 7 to 8 months. If you take a look at this first slide, what it really does is it emphasizes that we have known about human coronaviruses for a very long period of time right now. There are a number of coronaviruses. They are very much endemic in a bat population and other intermediate hosts, but they're also human coronaviruses. And the 4 that are shown, highlighted with the yellow boxes on this slide, are the 4 human coronaviruses that are responsible for anywhere from 15 to 30% of the common colds which all of us repetitively experience during the winter months. In 2002, we had our first experience with a pandemic coronavirus with SARS, or the severe acute respiratory syndrome, which jumped species from a bat to a civet cat to a human, leading to an outbreak of about 8,000 cases globally, with close to 800 deaths. And then 10 years later, in 2012, the Middle East respiratory syndrome, another pandemic human coronavirus that again went from a bat to a camel to a human. So if you look at that, we've had over the last 18 years now experience with 2 pandemic coronaviruses, one of which was a true global outbreak, and the other which is still lingering in certain parts of the world, including and particularly the Middle East. Fast forward to where we are today, and at the end of 2019, the beginning of 2020, in China, another potentially pandemic and now absolutely pandemic human coronavirus was identified, again, very likely jumping species when one looks at the sequences of the virus, from a bat reservoir to likely an intermediate host that has not been identified, and again to humans. It started off as about 20 cases identified, concentrated in a wet market in Wuhan, China, to what we have right now. It has been referred to, as I'll get to in a moment, because of the phylogenetic proximity to the original SARS coronavirus 1, it's referred to now as SARS coronavirus 2. And just to be clear, the disease that it's caused is called COVID-19, or coronavirus disease 2019, referring to its identification at the very end of December of 2019. And as I mentioned a moment ago, the virus itself is referred to as SARS coronavirus 2. So where are we epidemiologically with this now global pandemic of historic proportions? There are close to 28 million cases and almost 900,000 deaths globally. Sadly, the United States of America is the country that was most severely hit and continues to be the country with the most infections per day and the most deaths per day. Right now, the latest data show that there are over 6 million reported cases in the United States and almost 190,000 reported deaths. If you look at the pattern of infection, it shows why it is still so problematic in the United States. If you look at the blue curve on this slide, the European Union, where you had a peak early on before the peak in the United States, which then went down to a reasonable baseline, which only recently has gone up to about 20,000 per day in the European Union. However, in the United States, we had our peak, which was dominated by the northeastern part of the country, particularly the New York metropolitan area. But when it came down to a baseline, the baseline was unacceptably high at about 20,000 cases per day. However, as we began to attempt to open up the economy, particularly in some of the southern states like Florida, Texas, California, and Arizona, we had a considerable surge that went up to approximately 70,000 cases per day. That is now leveled off down between 39 and 45,000 cases per day, an unacceptable level for a baseline, which is the reason why this pandemic is still extremely problematic in the United States. Let's go quickly over to some of the fundamental virology. This is a beta coronavirus. It's an RNA virus with multiple structural genes, the most important of which is the now famous S or spike protein, which on electron microscopy gives the virus its appearance of a crown, hence the word corona in the name of the virus, coronavirus. It's been identified that the ACE2 receptor is the natural cell receptor binding to the receptor binding domain of the spike protein. The ACE receptor is widely distributed throughout the body in the upper and lower respiratory tract, as well as the GI tract and the cardiovascular system. With regard to transmission, well documented now that this is a respiratory-borne virus transmitted between people in close contacts, usually through respiratory droplets, as well as now increasing evidence that small aerosolized particles also transmit the virus. Surfaces can be infected, but it is unclear the extent to which this contributes to transmission. The virus is found in a number of body fluids, but again, the role in transmission is unclear. And finally, a number of animals, including some domesticated animals, have rarely been demonstrated to harbor the virus. Again, it is quite unclear and likely does not play any significant role in human transmission. Some important issues with regard to this virus. One very important, about 40 to 45% of individuals who are infected are without symptoms at all throughout the course of infection. This is complicated by the fact that we now know, although we did not know it months ago, that about 50% of all transmissions occur from an asymptomatic individual to an uninfected individual, which makes it extremely problematic when you're doing contact tracing and trying to get to the source of the community spread that we now see so commonly. With regard to clinical manifestations, the clinical presentation is very similar to a flu-like syndrome, with the symptomatology shown on this slide. Of interest is that there's a peculiar loss of smell and taste in many patients that precedes the onset of the classical respiratory symptoms. Another important feature of this disease is the extraordinarily wide spectrum. I have already mentioned that about 40 to 45% of the people have no symptoms at all. But if you look at the range of symptoms, it goes from mild symptoms, not even requiring staying home in bed, although you recommend people do stay home in order not to transmit it, to individuals who are at bed weeks at a time and take months to recover, to those who have hospitalization, some requiring intensive care, some requiring intubation and ventilation, and some who go on to die. So very unusual in the extraordinary range of symptomatology. If you look at the percentage of different levels of disease, the overwhelming majority of individuals have mild to moderate disease, not requiring any specific intervention. However, about 15 to 20% of individuals develop severe and even critical disease. The case fatality rate varies. For those who require ventilation in the United States court, the mortality is approximately 20 to 25%. The manifestations of severe disease are protean. Acute respiratory distress syndrome is the predominant feature, but there are a number of other organ systems involved, including the heart with arrhythmias and cardiomyopathy, kidney injury, neurological, hyperinflammatory syndromes, an interesting hypercoagulable state with microthrombi in small vessels, and we are now seeing acute strokes due to thromboembolic phenomenon in larger vessels. It has been recently reported that a number of children develop a multi-system inflammatory syndrome that is very reminiscent of Kawasaki disease, which is again a systemic inflammatory syndrome in children. We are noticing now, as we have the opportunity to follow people for a long period of time, that those who recover from the virological component of COVID-19 often have chronic symptoms, including something like brain fog or a difficulty in concentration. But there are also issues such as cardiac damage, neurological, myalgias, and chronic fatigue. If you look at the people who are at increased risk for severe COVID illness, they're divided into two major groups. First, there are older adults. And if you look at the parameter of the rate per 100,000 population of hospitalizations grouped by age, this slide is very dramatic because, as you see on the left-hand part of the slide, the very low rate of hospitalization among young people, which gradually increases to a rather profound rate in individuals between 75 and 85 plus years. In addition, and this is very important, that people of any age with certain underlying medical conditions are at high risk for severe disease. And these are some of the underlying conditions: severe heart disease, kidney disease, chronic obstructive pulmonary disease, type 2 diabetes, obesity, and immunosuppression due to a variety of conditions, including cancer and solid organ transplantation. There are other conditions where the relationship to increased risk for severe disease is less profound, but nonetheless present. They are listed on this slide. I'll point out one or two of them that are particularly important, and that is hypertension, type 1 diabetes, and a variety of other conditions. Vis-a-vis HIV-infected individuals, we have now looked at the literature very carefully, and for the most part, an HIV-infected person who is on antiretroviral therapy, who has a relatively normal CD4 count, apart from the other comorbidities which that individual may have, the very state of HIV infection that is well controlled does not render that person at a very high risk at all, more than the general population of severe illness. Although we know that patients with HIV often have a greater incidence of the comorbidities that do give them a higher risk apart from their HIV infection. When one looks at persons living with HIV, an analysis of 8 studies in Europe showed similar rates of SARS coronavirus in persons with HIV. And as I mentioned just a moment ago, it's the comorbidities that these individuals have more than anything else that renders them at a higher risk of severe disease. Moving on to racial and ethnic disparities, it's very clear and disturbing that in this country, there's a great disparity among African Americans, Latinx, and American Indian, Alaskan, and Pacific Islanders who have a higher rate of infection and a higher rate of serious complications. This slide is very telling. Again, if you go to the parameter of the rate of hospitalizations per 100,000 population, take a look at the top bar, in which Black non-Hispanics are 333 per 100,000 compared to the lower bar of whites, which are 71 per 100,000. This is also true with regarding deaths per 100,000, comparing the upper bar of African Americans that are 89 compared to whites, which are 37 in the bar in the middle of the slide. Moving on to diagnostics. The diagnostics fall into two major categories. One, when you want to specifically know if an individual is infected with SARS coronavirus 2, the standard test is a PCR to do RNA amplification, usually from a swab of the nasopharynx. Generally, the results comes back in a few days. It's quite expensive, but its sensitivity and specificity is quite high. We now have a number of screening or antigen tests, which are easier to do, quicker, in some respects, less sensitive. However, they can be done in multiples of tests every week. Most recently, Abbott has come out with a very important advance of a Binax Now COVID-19 card, which is highly specific and sensitive, and in 15 minutes, you get the result of the antigen test. This is now being widely distributed to nursing homes, schools, prisons, and places where you might have outbreaks where you want to do continual screening. Let me move on to prevention. There are personal preventive measures that we continue to preach about, including diligent hand washing, avoiding close contacts, wearing a mask universally with any kind of a covering of the nose and the mouth, avoid face touching, and do regular cleaning of surfaces. Broader public health measures include physical distancing orders, stay-at-home orders, modification of school and non-essential business schedules, including closures, bans on public gatherings, as well as travel restrictions, and a variety of mechanisms of contact tracing and quarantine. With regard to the treatment of COVID-19, the United States NIH has put out a treatment guidelines panel link in which individuals can log on and use this living document, which in real time updates clinical data related to published as well as unpublished clinical trials. In fact, the guidelines have now recommended two treatments, which I'll get to in a moment. But before I do, there are examples of other investigational therapies that are currently in clinical trial, including antivirals, direct antiviral molecules, still evaluating convalescent plasma, hyperimmune globulin, monoclonal antibodies, modulators of inflammatory response, such as cytokine inhibitors, as well as anticoagulants to address the hypercoagulable state that I mentioned just a few minutes ago. Two of the important studies that were randomized placebo-controlled trial, both of which have now been published, is the remdesivir study, which was done in 10 countries and over 1,000 individuals, which showed in a randomized placebo-controlled trial in hospitalized patients with pulmonary involvement that remdesivir had a significantly faster time to recovery than those individuals who received placebo alone. In a study performed in the United Kingdom, again in thousands of individuals, in a randomized placebo-controlled trial, it was shown very clearly that mortality in patients who were receiving ventilation or requiring oxygen had a significant decrease in mortality. Of note, when the patients who were early in the course were given dexamethasone, not only was there not a favorable response, but there appeared to be a deleterious effect, going along with what we know about the pathogenesis of disease, that early on it is much better to suppress the virus and leave the immune function as well as inflammation intact. Whereas late in the course of disease, the virus is less of a driver than the pathogenic process, as opposed to the inflammatory response, which is often aberrant, hence the beneficial effect of dexamethasone. And finally, with regard to vaccines, there are a number of candidates, 6 or 7, that are now being supported one way or the other, either directly or indirectly, by the US government. 3 of them, as I'll get into in a moment, are in phase 3 trials, we've adapted what's called a strategic approach to try and harmonize the studies with regard to a common data and safety monitoring board, common primary and secondary endpoints, and common immunological parameters to be followed. There are 3 separate platforms that are being pursued: nucleic acid, namely messenger RNA, viral vectors, including chimp adeno, human adeno, VSV, and measles, as well as a protein subunit. And as shown on the right-hand part of the slide, there are 3 of these now in phase 3 trial, and we would hope by the time we get to the end of this calendar year, in November or December, that we will know whether one or more of these are safe and effective. And we're actually cautiously optimistic that we will reach that goal because of the favorable responses we've seen both in the animal models as well as in earlier studies. So let me close with this slide, which gives the link to the COVID-19 Prevention Network for those who want to consider volunteering for any of the clinical trials, particularly the vaccine. You could log on to coronaviruspreventionnetwork.org. Again, that's coronaviruspreventionnetwork.org. So I'll stop there, and I want to again thank the organizers for giving me the opportunity to make this presentation. Thank you.
Thank you very much, Dr. Fauci, for a master class in COVID-19 we've come to expect from you. But as I mentioned in my introduction of you, we rely on you for unvarnished truth. And we heard from several mayors in our high-level panel this morning their hope for a vaccine. If we watch television on a daily basis, we hear all types of news about when we might anticipate one. Could you just speak to that issue concretely and let us know what we can expect?
Yes, I believe, Jose, that we can expect that by the time we get, see, right now, as I mentioned, there are 3 of the trials that are at the phase 3 level. Another will go into phase 3 at the end of September, and another 2 will go into phase 3 as we go into the end of October. For the 3 that are in phase 3 right now, it's generally a prime and a boost. Prime on day 0, boost on day 21 to 28. So then you have to wait at least a month or more following that to get any indication of what the efficacy and safety is. So we're really talking about a reasonable projection that by November or December, we will know the results of the study. I think that they are going to be favorable, but though, as you well know, as well as anybody, you can never guarantee anything when you're dealing with vaccine development. But it looks like we likely will know by November, December. Is there a possibility, the question everyone asks, that we'll know by October? It certainly is a possibility, but I think it's unlikely that we'll get a definitive answer by then, and much more likely that we'll know by the end of November, December. That being said, the doses are already being produced. So there will be some doses available by the end of the year, measured in the millions. As we get to January, February, it will be in the tens of millions. And as we get to mid-2021, it will be hundreds of millions. So I would imagine that by the time we get to mid-2021, towards the end of 2021, there will be enough vaccine to vaccinate anyone who wants to be vaccinated in the United States. And certainly this will be shared through a variety of mechanisms with other countries throughout the world.
Thank you. One more question for you. And it's a question that I asked the mayors, and certainly is relevant for public health leaders as well. And that is, what crisis leadership skills have you had to exercise in relation to this pandemic particularly that surprised you?
Well, I'm not so sure it was a surprise, but it certainly is the reality of dealing with an extraordinary, historic pandemic in the middle of a highly divisive state that we're in. I mean, the politicization, the hostility back and forth is something I've been through multiple outbreaks over the last 35 to 40 years, as you well know. I've never seen a situation where there's been as much divisiveness. So you have to be able to function in the context of good public health practices at the same time that it seems that everything is politicized, which is really unfortunate.
Well, thank you so very much for your leadership. You are a hero to many of us. I think you know that. And we're very grateful to know that you are at the leading edge of research to end this pandemic. Thank you so much.
Thank you, Jose. It's a pleasure to be with you. Thank you for having me.
Thank you so much. Ladies and gentlemen.